Well, classification is all about radiological assessment, so I will have to repeat a lot of things. But I think it's not too bad, because radiological assessment of acetabular fractures is difficult, and we have to learn that, because the classification is the keystone for decision making, also for the choice of the good approach if we want to operate the acetabular. And therefore, I think it's not too bad that we repeat some of these points. Classification is needed for decision making, choice of the good approach, and only with a good approach you will be able to reduce the fracture correctly, and only after a good reduction you will have a good long-term outcome of the hip. It's different. The hip, or the acetabulum, which is part of the hip, is a joint. The pelvic ring is not. It's a construction of stability. So Marvin Tile used to say, a pelvic trauma limps to death. It's not true. Pelvic trauma bleeds to death, and a hip or an acetabular fracture limps to death if you don't treat them correctly. And these are the pioneers of acetabular surgery. You will certainly hear more about them, or about Letournel especially, because he invented a lot of things in acetabular surgery, and he also described, together with his two chiefs, these are brothers, the classification that we use today. There are other classifications, but the mostly used is the classification of Letournel and Judet. And you see he died already in 1994 at the age of about 67 or 66, which is too young for him. This is the original paper in December 1964 in the GBGS, American Fractures of the Acetabulum Classification Surgical Approach for Open Reduction. And they reported about, I think, 35 patients. Yeah? Robert Judet was the first one, he was the chief. Jean Judet, the brother, and Letournel, he was the pupil. And you have seen this drawing already. They came up with a very important design of the acetabulum. They presented the idea of two columns. And you can look at the acetabulum in many ways. But if you look at the acetabulum as Letournel and Judet is doing, or were doing, then you will understand also how they came to the classification. They described an anterior column in white and a posterior column in red here, and the acetabular cavity is just between both. And then you have the connection to the sacroiliac joint. And that's the drawing in their original paper, December 1964, long time before we had a CT scan. Posterior column, they call it the ischial column, the anterior column not going up at that time, the iliopubic column. And between, on the medial side, they had this quadrilateral surface name we still use today. If you see this artificial bone model, then you immediately recognize what is meant with the anterior column starting at the upper part of the iliac wing and going down to the symphysis pubis. Very large but thin. And the posterior column is smaller but thick, and it's the ischium. Here it's the ilium, the pubis, it's the ischium, and it's the posterior part of the acetabulum. You see the acetabular cavity is just cut in two parts. One part is belonging to the anterior column, and one part is belonging to the posterior column. So how to look at it, and we have heard from Professor Azim a very good lecture about that. We have to look at conventional X-rays, we have to look at CT scans, and I always start with the transverse cuts, the classical cuts of the CT, and then I go to the two-dimensional reconstructions, as you see one here, a coronal reconstruction. This is of the pelvis. We can also have it only of the acetabulum. We can have sagittal reconstructions. And then we can have three-dimensional reconstructions. As you know, you have seen that already, and we will come back to that. So, and then you have heard about the lines. Yeah? The ilioinguinal line or iliopectineal line. The ilioischial line, more or less vertically. They come together here. The foramen. The lateral border of the posterior wall. The lateral border of the anterior wall. Normally these lines do not cross each other. They start here at the upside. Unless you have a retroversion of the hip. The iliac crest or iliac wing. So you have to look at these lines systematically and see if they are interrupted or not interrupted. And you will see this iliopectineal line is part of the anterior column. The ilioischial line is part of the posterior column. So if you look at it and you see it's broken, then you will immediately think, okay, the anterior column is broken, or the posterior column is broken. Then you have to look at where is that fracture going to. Does it go from posterior to anterior? Does it remain posteriorly? Or is it only at the edge of the acetabulum? And we can do the same. You can read that very nicely in the book of Letournel. We can do that the same way in the ala view and in the obturator view. Here you see an ala view, and you recognize the fractures going down from the iliac crest to the foramen, and you will also see some specific lines that demark the anterior column and the posterior column. The same here, the anterior column margin. I go back. Here the typical line for an intact posterior column margin. And you will put all this information together and make a first provisional diagnosis. And you say, I think this is a transverse fracture with a posterior wall. That would be, let's say, your classification, but provisional. And then you look at CT and you try to confirm this diagnosis. You say, okay, I'm right, because I see more in the CT scan, and that gives me the certitude. As Professor Azim said, we have the axial transections, we have the reconstructions, coronal and sagittal, and we have three-dimensional reconstructions, which is a view of the whole, but from outside. You don't look inside the bone anymore. Here you look inside the bone, here you look inside the bone, you look into the cavity. If you take away this femur, you can also look into the cavity of the acetabulum, but only from outside. You see surfaces. You don't see what happens inside. And this is the classical transverse cut at the level of the acetabulum here, the fossa acetabuli, at the middle of the acetabular cavity. And if your fracture is horizontal in this cut, there is a disruption between the anterior column and the posterior column. You don't know yet which column is displaced, but you know it's a column fracture. If you have a coronal fracture, is a column fracture. You see here, this is more or less horizontal. And you may imagine here that the anterior column is displaced. But you have to make sure in other views. If you have a sagittal fracture line, then we are talking about a transverse fracture pattern, going from anterior to posterior, cutting through both columns. And if we have oblique fracture lines, mostly at the margins of the acetabulum, we have wall fractures. It can be a little bit larger, this fracture fragment, also this fracture fragment can be larger. Then we talk about wall fractures, anterior wall or posterior wall. So if we have such a fracture pattern at the CT scan, this is just above the acetabulum. This is at the roof, just above the roof. What do we recognize? We recognize a horizontal fracture pattern, and we recognize a vertical fracture pattern. In combination, it's like a T. So we can call that an anterior column fracture and a posterior hemi-transverse. It's not a complete transverse, only the posterior part is disrupted in two pieces. So then we have the diagnosis. It's an anterior column, posterior hemi-transverse. And that's the classification, is the basis of the classification of Letournel and Judet. They distinguish between 10 fracture types, and they organize them in two families. Simple fracture forms is what they call, it's not simple to operate, it's just a simple fracture type. And combined fracture forms. What does that mean? The simple fracture form has one main fracture line. So essentially there are two parts. There can be multiple small parts additionally, but we have one main fracture line. And in the combined fracture forms, we have several main fracture fragments, which means several main fracture lines. It can start with 3, can go to 5, 6 in certain fracture forms. So one main fracture line, posterior wall, a marginal fracture. One main fracture line, posterior column, going through the acetabulum, through the foramen, excuse me, certainly also through the acetabulum. Anterior wall, also going through, but here ending at the anterior column, above and below the acetabulum. Anterior column fractures, going through the acetabulum, but going very high, very low, going through the foramen as well. And transverse fractures, from behind to, from anterior to posterior, or vice versa, going through both columns. Then combined fracture forms. You see here a transverse with a posterior wall. Here you see a column fracture with a posterior wall. Here you see an anterior wall and a posterior hemi-transverse. Here you see a T-type fracture, which is in the family of the transverse fractures, but there is more. There is one fracture line going down. So this and this and this is totally separated. And then we have two column fractures. And that's a specific entity because no part of the acetabulum is still attached to the axial skeleton. So the whole acetabular cavity is loose. And that's the reason they call it floating acetabulum. But you have to remind, all these fractures involve two columns, but they are not two column fractures in this definition. They involve the two columns. That's the difference. So let's go and look at some examples, and then we do that in every time the same way. We look at the conventional X-rays and we look at the CT scans after each other, and we have always the same questions to answer. Is there an interruption of the iliopectineal line? Is there an interruption of the ilioischial line, of the obturator foramen, of the iliac wing, of the posterior wall? Then you will also be able to subclassify and make a provisional diagnosis. And then you look at the CT cuts, the axial CT cuts. What is the orientation of the main fracture lines? Excuse me. And then at the end, is there an intact connection between the joint and the acetabulum? So do we have a floating acetabulum, yes or no? So that's case one. What you will see here, the hip is dislocated, the lines are intact, but there is a fracture above the head that is a valve. So you have a provisional diagnosis. I think this is a posterior wall. You see very nicely this piece, especially in the obturator view, with the dislocation of the head. And if you look now at the CT cuts from the ilium, the acetabulum, again the acetabulum, and below the obturator foramen, you will see the iliac wing is intact. There is an oblique main fracture line, and there is an intact obturator foramen. So that means it's a wall fracture. And then you have the diagnosis posterior wall fracture. There is something specific there. I will talk later about this. There is a piece that is rotated away. It's impacted. This is subchondral impaction, and this will modify your treatment, but also modify the prognosis. Look at this line here. You recognize a small fracture here. It's difficult to see something else. If you look at the ala and obturator view, it's difficult to look. What do you see here? You see a line is going up in the reconstructions, the 3D reconstructions, surface rendering. And the same here. So if you look now at the CT scan, you see much more. You see an interruption of the iliac wing, an interruption but a horizontal plane fracture above the acetabulum, going down and going down. So this is an anterior column fracture. And you didn't see that in the AP and in the ala obturator view. That means you need this CT scans to be sure. Another example. This is a column that is displaced with an additional fracture fragment. This patient had a sciatic nerve palsy when he came in. I remember that. And that's the situation after reduction of the head. You still see this piece of bone. You still see the fracture. Here is the anterior column remains intact, so it's a posterior column fracture, probably. And what you see here, intact iliac wing, a coronal fracture line, again here, but not this piece is displaced now, it's this piece that is displaced, and here you see the fracture in the obturator foramen and the distal tuberosity. So this is a posterior column fracture with an additional smaller piece. Case 4, what do you see? You see the posterior column displaced, but you see an additional fragment above the head. So you have already a primary diagnosis, posterior column, posterior wall perhaps. What do we see in the CTs? Well, we see the iliac wing is intact. We see a sagittal main fracture line. which is a transverse type of fracture. So my first diagnosis is corrected here. It's not a posterior column, it's a transverse fracture type. And I have an oblique fracture line here. You see this piece of bone belongs there. The head is displaced between all these fragments. So you have a combination of a transverse with a posterior wall fracture. And the obturator foramen is intact, because the transverse fracture does not involve the obturator foramen. Another example here, again, you recognize immediately the ilioischial line is broken, the ilioinguinal line is broken, several pieces here around the acetabulum on the medial side, so anterior wall, but the fracture is also going to the posterior part. So you see it here, and you see it there, going through the lateral border of the posterior column as well. So what do we have? An intact iliac wing, a coronal main fracture line, and a sagittal main fracture line, a second fracture line. So we combine this information again, and we have an anterior column, posterior hemitransverse, and the fracture is going down, the anterior column fracture is going down through the obturator foramen in the lower pubic ramus. So anterior column, posterior hemitransverse. And if you look now, is there any connection between the sacroiliac joint and the acetabulum? The answer is yes. This piece connects both. So this is not a bone column fracture. So intact connection. But here, perhaps that's different. Here, case number 6. What do we see? Perhaps this is a transverse fracture. We have to look at it. ALA and obturator view. You see this main fracture line, perhaps an additional fracture fragment, but this is one main fracture line. No, it's more. So don't jump into a conclusion. Look very nicely and carefully at your CT scans. You see there is a transverse fracture pattern, but there is also an extension towards laterally, or you can say it's different. This is the transverse fracture pattern, and this is the horizontal one. So perhaps, yeah, the sagittal main fracture line and a horizontal secondary fracture going through medially. That means we have a T-type lesion. And also here, in this case, there is a good connection between the sacroiliac joint and the acetabulum, so no bone column fracture. Here we have something different. You see the fracture starts there, goes down to there, severe displacement of the anterior and the posterior column, tilting of the acetabular roof. So a lot of information that says to you this is a complex fracture type. Certainly it's combined. It involves the anterior column from above to down, and it involves the posterior column. What do I have? Is this a bone column fracture, yes or no? Well, I don't see a connection between the sacroiliac joint and the acetabulum anymore. This is a floating acetabulum, which means this is a two-column fracture. So to summarize, Letournel and Judet described 10 fracture types, 5 so-called simple fracture types with one main fracture line, and 5 combined fracture types with at least 2 main fracture lines, 3 pieces. If you study the conventional X-rays with ALA and obturator, then you have to be able to classify 95% of the cases. If you have to exercise that. It's very important not to look at the CT scans first. You have to look at the information of the conventional X-ray. And then you have to look at CT. And this confirms your diagnosis, or you have to correct it, but it gives you also more information on the acetabular cavity. And these are the so-called modifiers. What is the trauma of the cartilage and the femoral head? So the CT examination, the CT examination gives you information about, is this a fracture or a fissure? How much is a fracture dislocated? Is there secondary congruence? Is there subchondral infarction? Is there damage to the femoral head? Do we have intra-articular fracture fragments? This is very difficult. Letournel could do that, but most of us cannot do that. To recognize an intra-articular fracture fragment, a subchondral infarction on conventional CT, on conventional X-rays, a Pipkin fracture, or a fragmentation, a lot of small fragments that are deperiostated, so do not have vascular blood supply anymore. And these are the so-called, excuse me, that's my lapse. These are the so-called modifiers. You have to look at them, and before you start the surgery, you have to talk with your patient and to say him, that's the fracture you have, that's the operative approach I will have to choose for that, but these are the modifiers that you also have. This is a subcategory of fractures that is especially difficult to treat with a less positive prognosis than the fractures without these modifiers. Thank you very much for your attention.